Started. Good morning, everybody. It is really nice to be back at the beginning of our Cardiology Grand Rounds series again. Thanks to all of you who are joining online. For those of you who don't know me, I'm Greg Roth. I'm the chair for our Cardiology Grand Rounds series. We have a really terrific schedule of speakers this year. I'm really excited for this opportunity for the division and all of our fellows and students and even people beyond that at the university and even beyond the university to come together for this really nice opportunity every Friday to discuss really important issues in the field of cardiovascular medicine. I want to just have a couple housekeeping comments and then we'll get started. So the first is I'd like to welcome our new program coordinator, Julia Campbell. You may be seeing some email from her. She's taking on Gavin's role. Thanks, Julia, for taking on all of the complex logistics of keeping the program running. I am frequently asked how long we will stay in this fully remote format. While we've streamed Grand Rounds for quite a while, we obviously had the opportunity to come together in person before the pandemic. So I will be working with the division and checking with recommendations from the university. And our goal is to be back in person as soon as we can be, though it does seem like for the foreseeable future, we will continue with this remote only format that we have right now. Finally, I just want to welcome anyone to reach out to me during the year if there are questions, if there are suggestions. I'm really happy to talk about opportunities to bring new voices into our Grand Round series. That's one of our goals. And so please don't hesitate to email me or find me. And I'm always happy to talk about what we can do to make Grand Rounds better. So today, it's really great to be able to hand the virtual Zoom screen over to Professor Jim Kirkpatrick and Denise Dudzinski. So many of you will know both of these folks, and they have annually helped kick off our Grand Round series with their presentations focused on bioethics in the field of cardiovascular medicine. So Jim is our chief of cardiac imaging here at the University of Washington and also the chair of the ethics committee at the University of Washington Montlake campus. And Denise is the chair of our Department of Bioethics and Humanities. They've also brought in a panel today to join them in this really important topic, inequities in advanced cardiovascular therapies. So a great pleasure to have them. Denise, Jim, take it away.
Greg, thank you so much. And I want to give a special thanks to Greg for his foresight in actually putting together really this wonderful way to kick off the Cardiology Grand Rounds series every year. We've done this for the past few years, and it has been, I think, very enlightening and educational for me, and a great opportunity that I have had to continue to partner with the Department of Bioethics and Humanities. In addition to Denise Dudzinski, who is the chair of that department, I also want to introduce Nancy Sugg. She is the director of the Pioneer Square Clinic. And if you don't know anything about the Pioneer Square Clinic, you are really missing out. I've had the chance to go down there and see the operation. It is amazing. They provide some of the highest quality primary care available to our homeless population down in Pioneer Square, and actually beyond that as well. And we are so fortunate to have Nancy come and present a case for us today to really highlight this important topic that we're discussing. In addition, we have Gina Campilia with us. She is an assistant professor in the Department of Bioethics and Humanities and is coming from a philosophical background, but she is also a healthcare ethics consultant in multiple of our hospitals in the University of Washington system. And she is basically batting cleanup today. She's going to be able to provide and put into context some of these important issues that we're going to be discussing and really, in a sense, bring home the discussion. Following Gina's presentation, we're going to actually open the floor. We have a number of prepared questions that we're going to be asking our panelists and you, the audience. So we really encourage everyone to chime in, and not just about these questions that we'll have, but also about anything else in relation to this topic, and in particular that has struck you during the presentations. So here's the disclosure slide. None of us have any financial relationships, not surprisingly, that with any companies that would impair our ability to present this topic in a fair and balanced manner. But there is a very, very important disclosure that we need to get out of the way, just straight up. And this is something that Gina crafted, and I think it is worth going through here. First of all, in case you haven't noticed, all four of us in this session identify as white. And this means that we can only offer a start to the bigger conversation that is and should be taking place around equity in cardiovascular care. We do not and don't pretend to hold the necessary expertise related to being part of Black, Indigenous, or POC communities at all. However, all of us, as I'm sure many who are listening, are committed to equity, diversity, and inclusion. We know that cardiology and clinical ethics have a lot of work to do to fulfill this commitment. And in fact, the presentation of only four of us up here, who all identify as white, is really a sign of that. In this session, we are hoping to offer some professional insights related to our practice as clinicians and ethicists and our collaborations with BIPOC colleagues in our fields. And our goal is to ask important questions in support of equity, knowing that this conversation is going to be insufficient and it needs to continue with greater inclusion of colleagues and patients who are most affected by the stark inequalities in healthcare. So here's our outline today. We're going to discuss disparities in advanced cardiac therapies, really to set the stage. Then we're going to move on to our case presentation by Nancy. And then we're going to have a little bit of case analysis by me. Finally, Gina is going to end with ethical frameworks, particularly addressing this issue of utilitarianism versus equity. And then we're going to throw everything wide open for the discussion. So without further ado, I'd like to turn things over to Denise Dudzinski, Professor and Chair in the Department of Bioethics and Humanities. Denise.
Hey, thanks very much. It's good to be here with all of you. So the next slide, please. And I just want to start, there are a lot of different graphics that help us understand this issue of equity and equality. I kind of like this one. It's one I recently found. And you can see that we're basically focusing, all of us together are focusing in these last two cells. And what can we do to improve equity? And more importantly, what can we do to sort of right systemic injustices in such a way that there's more of a propensity overall for justice and for equity in that way. This is obviously a really hard job, and we're in this together. And as Jim said, nothing we discuss is unique to cardiology. But when we do this together, I think justice is possible. So next slide, please. So there's quite a bit of literature out there on sort of inequities and bias in all of our fields. But in advanced heart failure, here's one that came out in the last year. And you can see the quick take-home points that heart failure disparities are worsening across race, ethnicity, and sex. That social determinants of health, including bias and racism, do directly impact cardiovascular care, and that research to achieve equity in heart failure is urgently needed. Next slide, please. So this data is from the CDC, and I'm sure all of you are more familiar with this data than I am, but it's good news that the death rates for heart disease are falling from all races and ethnicities pictured. But non-Hispanic Black patients are more than twice as likely as non-Hispanic Asian or Pacific Islanders, that's the group with the lowest mortality, to die of heart disease. So I'm going to focus a little bit here on Black patients because they seem to have the greatest disparity and need more of our care as we try to address the inequities. Next slide. So looking at both more primary care and advanced heart failure. So Black patients have the highest rate of heart failure and the greatest mortality. Among patients presenting with acute MI, Black patients are less likely to be admitted to medical facilities with revascularization capabilities and high quality acute MI outcomes. Black patients have lower odds of achieving a door to balloon time of less than 90 minutes and see longer revascularization times than their white counterparts. Black patients have been found to receive less patient-centered care, as evidenced by less psychosocial and rapport building and shorter medical visits than white counterparts with similar CVD risk factor profiles. In one study, just looking at one center's experience, they found that there was, in some places, there was some parity, but in groups from 60 to 69-year-olds, approval for VAD eval was skewed toward white patients. And I think we see that more generally. Racial and ethnic minorities receive less than 40% of advanced heart failure therapies, transplants, and VADs. And then another well-publicized study shows that Black patients are admitted to the ICU, are less likely than whites to receive primary care from cardiologists. So we kind of see the picture. There's much more data that we could bring, but in the interest of conversation, this just gives us a picture. Next slide. Just looking here, this is publicly available data from our transplant center. Again, we're in this together, and we can see here that our center also has some issues with racial disparity and gender disparity as well, which I'm going to talk about a little bit here. So there's really many, many more white patients and many, many more male patients. And so the question we're going to ask is, are there things that are in our power to do to improve this moving forward? And many of you have the answers to some of those questions. Next slide. So looking at gender, cardiovascular disease is the leading cause of death for women. There are 1 in 3 deaths per year. Women, I think this is very well known, are underrepresented in cardiovascular research. And so some of the take-home messages don't always get translated as well as they need to. And so that's another important part of this. There was a large study of 11 million women run by Johns Hopkins that found that communication and other factors were played a prominent role in some of the disparities. So compared with male participants, women with cardiovascular disease were overall 35% less likely to be prescribed preventive aspirin therapy and 45% less likely to be prescribed a statin. They were 23% more likely than men to report that their doctors never or only sometimes listened to them, and 20% more likely to report that their doctor never or only sometimes showed them respect. So you know, what's going on there? This is part of sort of the recommendation to continue research so we have a better understanding of what's happening there. 73% of transplant recipients are men. Incoming referral bias, which is something I'm going to show you another slide about, but basically this idea that referrals to advanced heart therapy come later, and this ends up really diminishing the overall well-being and outcomes for patients. And when that happens along gender or racial lines, that becomes a concern, of course. Door to balloon times are longer for women. Let's see, an average of 16 minutes longer from symptom onset to the intervention of the procedures, and 80% of VADs are implanted in men. So this is sort of a picture of some of that gender disparity. Next slide. So here, these authors talk a little bit about what might help, and I'm just pointing to the general issues. And these include more patient-centeredness with an attention to shared decision-making that can help in and of itself. Just the consistent use of shared decision-making can help with gender equity. Reducing those barriers to care in a variety of different ways. And sort of developing more innovative research and more inclusive research strategies. And then that last column, for example, you know, well, actually that bluish column, really having some unique approaches to different populations that are more tailored to what they need. And then finally, that last column is a little harder for us, any individual group to do, but it's sort of this broader sense of reform within the entire, so straightening that trunk of that tree more is something we're all working on together. Next slide, please. So late referral bias shows up in a lot of different ways, but here's one that's concerning, as you can see. So in UNOS's transplant registry, so this is over 5,500 patients comparing Black and white patients. Black and white candidates were equally likely to receive newer continuous flow LVADs, but Black candidates received them later in the disease course, and this ended up contributing to poorer waitlist outcomes among Black patients, including lower likelihood of receiving a heart transplant and greater likelihood of being removed from the waitlist due to worsening health. So the idea of really advocating early for these patients to get your care is one way that we can maybe help address this disparity. Next slide. And then finally, this author talks about the 5 domains that influence a physician's race-based clinical decision-making. One is different perceptions of the importance of race and acceptance or recognition of health disparities and social determinants of health. Some people are sort of minded that way and others may not be, and so that can make a difference. Patient level issues like barriers to access, which are a reflection of those social determinants, and other comorbidities. Of course, there are system level issues that include, you know, inadequate ancillary support or not enough time for people to provide the necessary additional time that might be required. In some communities, there's low trust in the healthcare system that can get played out in a variety of different ways in terms of care for patients. And then communication, which it does seem like we might have an opportunity here. Certainly, there are always challenges for us when we are trying to care for patients who do not speak our language. But there certainly are also ways that we can broach that challenge. And then really learning more and more about culturally appropriate communication and how we can do that better and better and in more of a partnered way. And then finally, just overt bias or racism. And again, I don't think we're ever going to completely eliminate bias or racism, but our goal is to eliminate as much as we possibly can. So this notion of being more attentive to where our biases lie is one part of the story of how to improve this and seek justice, but it's one part of a much larger picture that I know we're going to hear more about now. So thank you very much. And next slide, next speaker.
Thank you so much, Denise. That was excellent. So let's turn now to Nancy Sugg, and she is going to tell us a story.
Thank you so much. And I appreciate being invited to Grand Rounds this morning. I'm going to tell you about a patient that I've known for over a decade. He's a 58-year-old Afro-American male, college graduate, worked as an IT specialist and owned his own business in Chicago until 2007 when a left temporal infarct made him unable to work. He relocated to Seattle, feeling that he could probably find an IT job here easier, but he was never able to become fully employed again. And that resulted in him ending up homeless for a few years until he was again stably housed for the last 3 or 4 years. Unfortunately, in the interim, he developed an autoimmune disease that, despite treatment, caused severe damage of a solid organ. In September of 2020, he was referred for a transplant, as this was really considered to be the crucial next step in his survival. At the assessment, he was housed, he had insurance, he did not smoke, drink, or use drugs. He had no severe mental illness. He was compliant with his medications and kept his medical appointments. He was very engaged with his primary care clinic and had a strong support team there. But he was declined for transplant because he lacked social support. He was told he needed 24/7 care for 3 months post-transplant and would also need some fairly consistent care even in the period while he was awaiting the transplant. The patient then began to desperately attempt to put together some sort of social support. He lived alone, he had no roommates, no partner, no spouse. He is estranged from his family who lives outside of Washington State. He actually left home at the age of 18 because he was no longer following the Jehovah's Witness religion of his family, and they asked him to leave. So he began to try to locate his family and tried to see if any of them could come and help with the social support piece, but he was unable to locate any of his siblings. He approached his church about providing support, but they did not feel they could do the 24-hour, 7-day-a-week coverage. He called various skilled nursing facilities to see if he could privately pay, but it was well beyond his means to do that. Members of his clinic team looked into having a telephone service that could do check-ins with him on a regular basis, and that might have been appropriate for pre-transplant, but would not have been considered appropriate post-transplant for support. We looked into visiting nurse service. They would not have been able to provide any daily care during the post-transplant period. We approached the hospital about whether they could provide 2 or 3 months of SNF level care post-transplant through the bed readiness program, but the request was turned down. And I think mostly because they didn't really understand that he was truly not being transplanted simply because of the social support issue. The transplant team also stated that even if we were able to get a skilled nursing facility, that would not be considered an acceptable alternative to what is considered social support. In August, he was hospitalized for hypotension, and due to his designation of not being a transplant candidate, 2 subspecialty groups who were consulting on him felt that no further intervention was indicated as he was not heading to transplant. The patient did agree to be DNR/DNI, but he declined to be on comfort care. He was still very actively trying to put social support together. On the last day that I saw him, his landlord was in his hospital room, and they were attempting to see if his landlord's church might be able to put together support that he needed. The patient was discharged to a skilled nursing facility, and he died within a week of discharge.
Thank you so much, Nancy. It is a sobering end to a story, I think, that is illustrative in many ways. I had the privilege of being the ethics consultant on this particular case, and there were a number of things that actually really struck me about this. And as with any good ethics presentation, we have to start with a brief review of some of the basics. I think most people on this grand rounds are probably familiar with the principles of bioethics, the first of which is autonomy, something that is incredibly important in medicine, particularly in this country and in North America and bioethics in general, this idea that a patient has a right to determine what shall be done with her or his body. Next, we have beneficence. This is basically the idea that medicine and bioethics and everything we do really is about doing good. And closely related, of course, is the idea that we should not be doing harm. And this is often considered the areas where we have a lot of trade-off or conflict, the idea that we will try to do good, but we end up potentially doing harm, and we have to do our due diligence in trying to figure out whether that risk-benefit calculus is worth it, in a sense. We're all very used to that in cardiovascular medicine. And then there's this area of justice that we're talking about today. And we've already had wonderful discussions and illustrations of some of the issues that actually go into justice. And justice is often looked at among the pantheon here of the principles of bioethics. And not only is it listed fourth on most configurations of this, but it's also sort of seen as somewhat separate from these other areas. And I think what Nancy's case illustrates very nicely for us today is that actually justice can be put into a context in which it is at odds with our traditional sense of non-maleficence. Now, why exactly is that the case? And we're going to focus just on these two. Well, obviously, caregiver support is really important. Caregivers are important and essential to provide a number of different things. Nancy's case was a solid organ. It was not actually a heart. But I think it illustrates it. And I will tell you that the same sort of processes of requiring caregivers are pretty much in play across all organ transplants, or most of them at least, because transportation is necessary, getting to and from clinical appointments if something goes wrong. and for some reason that you're not going to be using the EMS system to get to the hospital. Caregivers are important to help patients remember instructions, especially in a post-op period. They may not be able to process everything quite as well as they should, so they certainly need help with that. Many caregivers are required to take vital signs and provide some basic wound care, certainly helping with medications. Again, if they can't remember instructions, they may not remember medications very well. Finances can be very complicated, not just because of the bills that they'll be receiving from UW Medicine, but in many other ways. A transplant and going through the whole process can be very disruptive to finances. And I think it goes without saying that help with performing activities of daily living is very important. And all of this really fits under this rubric of providing life-saving transplants to everyone, which is the goal that everybody is trying to do. And of course, if we don't actually provide the structure, don't have people in place to make sure that after transplant, the patient is still alive, that's not really doing anybody any good. But there are equity implications that Nancy's case really illustrated very nicely. And many of these things that we do in order to avoid harm, the non-maleficence, may have unintended consequences to disadvantage certain groups. Certainly those who are estranged from family for whatever reason are disadvantaged from policies like this. There could also be situations in which family members have to work 2 jobs just to keep the whole family afloat and may not be able to provide adequate caregiving support. And of course, there's advantage to those who belong to faith or other communities that can provide close friends to be in a position to be caregivers. And this is basically unfair because there are those who lack these sorts of situations. And then raises the question, then, are there ways to address these inequities without compromising our very important principle of non-maleficence? And of course, ethics is about raising these questions and then exploring them together to find ways to come up with the right ways of doing things. Another way to look at this is a sense of ethical weights. And basically, we are tasked both with pursuing fairness, but also stewardship of these important resources. Essentially, we in the cardiovascular and other transplant communities are given the duty to care for this important societal resource. And it depends, of course, on who owns what, as you see, but essentially, this is what we are tasked with doing. We don't want to waste anything, especially with something that is so rare and precious. So how do we decide who gets this? It's a very weighty question. And it involves resource utilization, burdens, equity, and fairness calculations. And putting together a system of fair access is sometimes very complex. And the recent changes to the UNOS allocation system has tried to address some of these issues, and we're not going to go into the details there, but it is very interesting. They wanted to reduce wait times, of course, but there are still geographic unfairness built into the systems, because if you live close to a transplant center, you are advantaged, and those who live farther away are disadvantaged. Of course, personal resources, income, family resources, and Learjets are very, very helpful if you want to get a transplant. So you could potentially be listed at multiple centers. And of course, access to gamers. And what we mean here are physicians who are interested in doing what is necessary to get their patients transplanted and might be willing to do things to game the system, whether those things are above board or sometimes not. And there are many examples, unfortunately, in the transplant world in which people have done things that have been a little bit outside the rules to accomplish this. But, public confidence is super important in this stewardship question, because if the public perceives that resources are not well used, they're less likely to donate. And this consideration drives a lot of concern about making sure that we are good about stewardship, and it should not be ignored. So now I want to turn to Gina to really bring this home and step back a little bit and give us a big perspective on particularly some of the ethical values that need to be considered in this whole arena. Gina?
Thanks, Jim. And thanks everybody for having me here. You can go to the next slide. So as Jim said, I'm going to step back a little. And as we think about how we think of fairness and how we think of the right way to steward resources in the US in particular, it really, there's a history to that. So while in US medicine, our dominant principle that we follow is respect for patient autonomy, and maybe respectfulness generally, but usually respect for patient autonomy. When we're distributing scarce resources in particular, like organ transplantation, then we shift to thinking about benefit and harm. We think about how do we prevent harm on the whole to society, and how do we provide the most benefit when we can't help everybody. And so the focus is often utilitarian, which is a framework that was developed by white European men. And when we take on a utilitarian framework, the idea is that when lives are at stake and not all can be saved, then it makes sense to focus on supporting the greatest good for the greatest number, which in many cases of distributing scarce healthcare resources means we interpret as meaning save the most lives or life years. And what's important to recognize about that is that when we interpret that utilitarian framework in that way, we're also overlapping it with egalitarianism. And so when we want to save the most lives or life years, we treat everybody the same in that calculus, right? And on one hand, that's what we should do. Everybody's life should be valued equally. But of course, in a society where we don't in fact value lives equally, people are not showing up in the same positions. And so we're treating everybody as subject to the same rules of protecting life and benefiting as many people as possible. But of course, as we've seen in the narrative today, as you saw in the other presentations and the data that's presented today, when we take on that framework, it doesn't treat people fairly and equally, because people are not showing up in equal positions. And so in reality, there's an exacerbation of healthcare inequities. It's not that utilitarianism is neutral, it's actually exacerbating the problem with health disparities in this country. And so the ethical analysis is never as simple as let's do our best to save the most lives or life years. In practice, this leads to saving the most privileged, who already have the most access to beneficial healthcare resources. So the issue here is that utilitarianism, and often conjoined with egalitarian frameworks, standardly don't center an analysis of social power at all. And so that means that by virtue of their own methodology, they don't seek to understand and respond to the inequitable distribution of resources and power. And justice really needs to center those things. So justice that addresses health disparities requires a different, or at least an additional, ethical analysis. Next slide, please, Jim. Okay, so a first step in this is seeking equity. As Denise talked about earlier, it's not the final step. So seeking equity is not about abandoning the goal to save lives and life years at all, but instead making sure that we're directly addressing inequities that arise through or are perpetuated by, even created by, a utilitarian calculus. So because utilitarianism exacerbates those inequities, we have to shift to a different framework like equity. Inequities are arising because we evaluate candidates as if they're arriving in the same positions when in fact they're not. And so we have to take that into account. So unlike a utilitarian framework, equity centers an analysis of power by looking at different needs, specifically needs that arise in the context of different forces of oppression like racism or sexism or cissexism. So often the focus in a context like this is to counteract the inequities we are seeing. A first step in that is often linked to narrative ethics, which is in part why we centered a narrative today. Narrative ethics is an approach that focuses on personal identity through story and personal experience and particular events in a life story of an individual or a community as a whole, which is important when thinking about justice. And these form a basis for ethical reflection and learning, and that's part of what we're doing today. So then the question is, how do we move from stories and counter stories, right? Stories that challenge dominant narratives, to finding ways to alter some of the conditions on which those stories have formed. And so one of the first steps is mitigating inequities, which means things like implicit bias training, maybe thinking about changes to the processes of referrals to avoid late referrals. Those sorts of activities are a first step in seeking justice as equity. But of course, that's not the end of the story either. Next slide. Ultimately, what we're really trying to strive for is transformative or responsive justice. And there are a lot of different interpretations of what this means, but the idea is that we're thinking towards a future in which mitigating inequities is not going to suffice. So mitigating inequities is a bridge to transformative or responsive justice. Implicit bias training helps individuals maybe mitigate their own biases, but it does not really address the biases in the systems themselves. To do that, we need to transform our practices so that they are truly inclusive and open to being completely deconstructed even. I don't know, we don't know what the answer is here. I don't know what transformative justice looks like in advanced cardiovascular therapies entirely. There have been some ideas out there and you've seen some of them today, and we're hoping to get to more in the discussion. I think we've really heard some great ideas. Some examples would include things like what you've heard already, like community advocates or leaders who really participate in a committee or evaluation panel. Thinking about funding, partnering with community leaders who will know best how to support their patients in need, such as through social support. So we've talked a little bit about that, and we'll do more in discussion. I'll just leave you with this as an open question for further investigation. Just thinking about how do we not only seek equity, but how do we actually transform practices to seek a truly responsive justice that addresses those inequities and disparities at the core of the system. Thanks, Jim.
Excellent. And I'm going to leave these references up just for a moment. Obviously, we can send them out to anyone who is interested in reading more about these things. And they come, of course, from a variety of different settings. And increasingly, we are seeing this getting into the cardiovascular literature as well. And I would encourage everybody to read up on this a bit more and also to contribute to it. There's not enough, particularly in the cardiovascular literature, despite the excellent efforts of many people working for many years on this issue. Well, let's move now to the discussion. I think we have a fair amount of time, and that really was by design. And I'm going to open it up first with just a sort of an overview here of some of the things we've talked about to hopefully stimulate thinking and responses from the audience as well as our panel. And one way to look at what we talked about is really at different levels of equity. There's the person level here that we talked about, and the case really illustrated very nicely. And I think all of us need to think about within our own practice how it is that we can respond to the calls for equity. And I think in particular, as Denise laid out very nicely, this is about access. This is about access for traditionally marginalized and underrepresented communities to get subspecialty medical management, to get our excellent interventional procedures, to get our structural heart procedures, to get ICDs and CRT and arrhythmia management that we can provide. In addition to, of course, so we talked about the transplant and, of course, VADs. And, you know, looking at some of the national trends, you don't see tremendous disparities jumping out in, say, the rates of VADs and things like that, if you look at some of the data that's there. But that doesn't always capture the fact that we are not referring patients early enough or at all perhaps, and patients just don't always have access. I was really struck by the data that Denise showed about the fact that, yes, maybe Black patients are referred for VADs, and heart transplant, but they actually receive them so much later that their outcomes are worse. And that is something I think we can do something about. From a system level perspective, and in this, the case also illustrated so nicely, when we have policies there, they need to be examined because there may be unintended biases that are hiding there. And we need to think about what are the equity implications when we put things together. And not that we would necessarily throw them out, not that we would necessarily be giving out exemptions left and right that are actually going to violate our principle of non-maleficence, but it is at least good to be aware and to think of the implications of what this is going to happen. And of course, that also has larger questions that we need to think about as one of our questions to the panel will come up. But the first question that I want to sort of pose to everybody here is, what role might narrative communitarian ethics play in advanced cardiac therapies decision-making? And Gina briefly went over this and discussed this issue. But what do people think? And I do really want to open this up to people using the chat box and raising hands, and want to be able to get a sense of what people think. But to start out, Gina, maybe you could talk a little bit more about what role narrative and communitarian ethics could play in advanced cardiac therapies.
Thanks, Jim. Yeah, I think so. I think it has a huge role to play, especially when you think about it in the sense of narrative versus counter narrative. So I think there are dominant narratives that play out in and play into our processes through which we evaluate patients, right? So think about the dominant narrative of who counts as a caregiver, or what counts as sufficient caregiving, and what caregiving looks like, or social support looks like, right? So we have a particular understanding of what that's supposed to be in our society, what it looks like, and what I often see as an ethics consultant are patients struggling to build a counter narrative to that, right? I can build social support, and this is what it looks like to me, and so helping to listening, as Nancy talked about, right? Not only listening to that counter narrative from the patient, but also helping them to build it when they're fighting against a narrative about what it's supposed to look like, and fighting to find support that's just not available in many ways in our system. I think that's a huge piece of this, and finding ways to take that counter narrative that we're hearing from that patient and change the system so that it includes the kind of support that would make sense to that patient, I think that's what the narrative leads to, right? And that's a huge position for narrative ethics.
Yeah, Nancy, how do you see this playing out when in your situation of trying to get people what they need?
So I think it's challenging sometimes if people don't use the same language when we're talking about what a patient needs. And I think that what I came up against over and over again was this really hard stop of, this is the model, this is what you have to have. And yes, there are equity issues, but this is not movable. And I think more conversations about really, what are the equity issues at play? What are the ethics at play that can pull us away from that very hard stop, I think are really needed, because that was the frustration the patient and I hit over and over again. It's just feeling like it was almost like we were communicating in a different language.
Yeah, that's an excellent point. Well, let's move on to this question, advocacy for equity. What can we do? And I think, again, turning to Nancy to actually think about some creative solutions. You went to the mat for this patient, and I will tell you that's one of the things the patients told me when I went in to talk to him. He had such confidence in you and his other physicians that you had his best interests in mind. And I think part of that was because you were very creative. So what other creative solutions do you think we need to begin to investigate if we're going to be true patient advocates?
So I think the first thing I want to talk about very briefly is the access issue. And I think it's important to understand that my patient never even saw a transplant surgeon because he could never get through that gate. There was that initial gate of an evaluation done. And if those boxes weren't totally checked off, then you never even moved forward to being able to see a transplant surgeon. So part of it, I felt like it was this disconnect between myself and the specialist I was referring to, that I had to go sort of through an intermediary step and was really limited in how I could advocate directly for my patient. So that was one thing. I think another big issue is just transparent information. And this is something that my patient brought up over and over again. He was struggling with, I just don't understand what they need. I just don't understand what they want. I'm trying to put something together, but it's unclear to me. And so I think that when we talk about social support, what does that really mean? What does that look like? And are there not other ways that we can do that? And who determines what is adequate? What checklist do they use? What are they looking at when they're saying you have adequate support, but you do not? And how do we make sure we keep bias out of that consideration? And this is a place where I think we really need to kind of look to the leaders in equity. And Paula Houston, the Chief Equity Officer, has a tool that is being rolled out to look at bias in policies and procedures. And I think that this would be a very good starting point when we look at things like eligibility for transplant, to really dig down and say, okay, what are we looking for? How are we making sure that bias isn't entering that equation while we do it? And so I think it's always, it's been said over and over again in this conversation that when you have a model of care, like our model of social support, can only really work in higher socioeconomic groups. And in our country, the higher socioeconomic groups tend to be white. So you are therefore really setting up a model that is going to leave out a significant number of Black, Indigenous, and people of color. And so what can we do to kind of work around that? So one of the problems that I had also was, again, what type of support and how long? First, in my group, I was told 2 to 3 months. You look at Hawaii, they say 1 month. Well, what does the data show? What is the support needed and how long does it need to be in place? And so part of that is trying to move away from this concept of social support, where there's an emphasis on you have a spouse, sister, family member, close friend who can do this, to actually just support. What support do you need to get through this transplant? And what does the data show are the key elements that have to be in place for that support? And I will say, Dr. Bernanke actually in the chat sent a really nice article. I was Googling on the side here. It really breaks down the type of support of all the different things that we ask these caregivers to do. And so, I think all of our patients would benefit from, whether we're just treating them for congestive heart failure and diabetes, but what are the ones that are critical to have in place? And what is the data that shows these are the ones that we really should put an emphasis on? Is it transportation? Is it taking your meds? Is it regular check-ins? And to really then put together a package of support as opposed to this concept of social support, so that more people can actually adequately do it. And then, of course, the big elephant in the room is funding. When you look on the transplant site at Queen's Hospital in Hawaii, they bring up the fact that people need caregivers. They also bring up the fact that they know some people can't afford to hire a caregiver or have family to do that. And then they invite people to work with the social worker to put together a package to be able to get them through. And I think that's where we really have to head. How do we build this piece of equity into the system so that more people actually can get to be transplanted. So, I think, again, some of this has to do with funding. How do we approach that? Well, there's a lot of different models we could think about. Do we advocate for insurance companies to cover these support systems that need to be in place for a liver transplant? It's simply, this is the cost of the transplant, this is the cost of the surgery, this is the cost of the medicines, this is the cost of support. And it is part of the package that insurance should cover for people who can't put those components in place that need to be there to get them through the transplant period. So I think that's one thing that we should definitely look at. We could go to the state and ask for special set aside funds for this. I know when HIV medications were first coming out and they were enormously expensive, the state actually put together funds to take care of people with HIV disease and to help pay for their medications. Maybe there should be a similar thing that we ask the state to do for people needing these more advanced therapies and transplants, that they actually can have a pool of money to draw from to do these things like transportation and medical support that they need. So those are just some random thoughts for me as having gone through this with my patient. I mean, I think we all realize that if we're really committed at the UW to health equity, it means that we need to provide those things that every patient may need in order to achieve health. And so I think we need to start really thinking about what we can do as an institution, and then what we can do in advocating with payers and the state to really make sure that more people have access to life-saving interventions.
Absolutely. Thank you so much. I want to turn to April, who has a comment.
Yeah, I just wanted to go back to the narrative issue. And one thing that struck me, and just for the other panelists so they know I am a heart failure transplant cardiologist. One thing that struck me about the narrative is that we don't include the narrative of how much work or what people have overcome to get those types of sort of social support, for example. And that in overcoming some of those barriers, those patients may actually be better candidates and more compliant over the long term because they've shown, a degree of savvy in getting things together that may be different than what, our narrative model of having a spouse that takes care of everything is. Because then, we've certainly seen cases where the spouse goes away and everything falls apart. So I think that's just something that we need to include, in these counter narratives. I do think we need to be more open when we're having these discussions about patients, about narratives and counter narratives. I had a patient last year who was only Spanish speaking, and it was during COVID where her family couldn't come in. And her family insisted on being on FaceTime 24/7 and throughout all of the conversations with her. And some of the healthcare providers were uncomfortable that the patient, quote, didn't really know what she was getting into, because it was all, even though we had separate interpreters too, they felt like her family was, quote unquote, overbearing. But the counter narrative of that is like, this is the world's most incredibly supportive family. Like, they're in it for her. And I think that we need to just be really careful. And I think as a transplant group, we need some sort of, trigger phrase good trigger phrase to be able to, in those situations as a group, say, hey, this is one of these situations. Let's talk super openly and think about all of the narratives that are going on here, and not put somebody in our, cis white boxes.
Excellent points. Any comments, responses?
I think that's a great point, April. And I think you're right that one of the best ways to do it is, and I'm not sure how you would build this into the practice exactly, not practicing in the same field, but having space to say, what is the narrative here? What's the dominant narrative here? And what are the possible counter narratives? And making sure to build those and center them so that they have greater power in the discussion, I think is exactly, as you said, is a huge piece of this. And often that's what ethics consultants are trying to do is search for those counter narratives and elevate them in some way.
Excellent point. There is a wonderful comment from Maya Baumgartner in the chat. I direct everyone to read that. But there's a question coming in from Aubrey. Where can we learn more about the equity and policy tool that we've mentioned?
So I know if you're at Harborview, Martine Pierre-Louis is the head of our equity there, and she could probably direct you to the tool. And then I would also just call or contact Paula Houston's office and talk more about that, because I know they're rolling it out and they're trying to get some familiarity with it. They definitely want to use it for any like new policies or new, sort of approaches to processes. But I think that they're also interested in looking at some of our hot points that we really need to look at. So I would contact Paula Houston's office.
Excellent. So let me ask another question of everyone here in the little bit of time that we have left. And that is, what is the role of including more diverse decision makers in these decision-making processes? So any of the panelists or anyone else like to comment on that?
So this is Denise. Can you hear me?
Yes.
Okay, great, thanks. I'm having some sound issues. So I think one of the things that, all the speakers Gina has really laid out nicely is this idea that, so if we take equity as one of the lenses, I think it's actually compatible with the utilitarian lens as long as you are focused on equity first. So if the idea is once the patients come to us, they haven't come to us from the same background. It was harder for some of our patients to even get where they are now because of the obstacles that are involved in racism, sexism, et cetera. So then what counts as equal treatment is actually to invest more in those families that need that additional assistance and haven't had it historically. And that's a way for them to catch up. So you're not favoring particular people, you're addressing a longstanding inequity that is a function of this kind of privilege. And so I think that plays into your question, Jim, in terms of how family members and other people can be included, right? So our arms open more widely under those circumstances to bring them in to the fold of opportunity that they have been excluded from for so long.
I think that's a very good point. And obviously, one of the things that our entire institution is trying to do is diversify ourselves so that diverse decision-making can play a role in these committees that are really tasked with some incredibly important things. But Janie brings up an excellent point in the chat box here too. Janie, I was wondering if you'd like to talk about this point that you just brought up as well.
Hopefully everyone can hear me.
Yes.
Okay, so I was just thinking about that example April gave because I know exactly which patient that was. It was a Harborview patient, and luckily Song also knew that patient. So I think she was well represented in any sort of meeting, but had Song never met her, that patient's family had actually come into clinic, and I similarly had found them a little overbearing over the phone, but in person they were lovely. So my point in the chat box was perhaps getting collateral information from the other providers that are involved in care would be helpful. And so in the example that you guys provided today, it sounds like in this case, the primary care doctor would have been the beacon of more insight and perhaps should be invited to provide that information to the transplant committees.
So again, thanks to everybody and hope you all have a great day. Take care.